Start talking.
Welcome to Fertility Factor Fiction. You got to adjust that TikTok one, man. It's on a huge angle. Just take it back down. Hi, everybody, and welcome to Fertility Factor Fiction. We are together on a Monday because tomorrow night is my birthday and I was forbidden from working. So I am your host, Dr. Rahi Victory, medical professional in infertility. I am double board certified reproductive endocrinology and infertility specialist, now licensed in 3 separate countries, Canada, the United States, and London, England, or I guess England, all of England and the UK, and hopefully Ireland soon as well. Very excited to start helping patients out there as well because they need better care than they are currently getting. So very exciting stuff coming up soon, and we will be taking the show to the UK as well. So exciting to start that out there. Nothing huge or tremendous in the fertility world recently, no major breakthroughs or anything like that, but there is some hope and stuff on the horizon. There's a new male birth control we're going to be talking about. And there is some work being done on looking at RNAs in sperm and whether or not we can predict fertilization, blastulation, and implantation. Turns out you might be able to do a sperm test, which will tell you how well you're going to do. So I am very, very excited about that potential as well. New research coming out all the time. Nothing super well established yet, but a lot of hope on some things out there. So very excited to have you all join us, and welcome to the show. Tonight I do not have an article to review, so I am just going to be basically answering questions, and I'm very excited to announce I'm going to be going to Germany, where we're going to visit our friend Jonathan Tettleman, a world famous opera singer. You can look him up at Tenor Tettleman, and the guy is phenomenal. So we're going to see him and watch him perform in a castle. Very, very cool.
So many questions is what everybody's saying.
Oh,
They
wow.
have so many questions about endo.
Okay. Yeah. Well, we had the whole endo post that went viral, and even better was the tiger with the sore butt. Yeah, I like that one a lot. That was really good. I guess that works better when it's connected for you, eh?
It's not black screen. I'm like, I swear I got this focus. But okay, here we go.
There you go.
Welcome to the show, everybody.
Welcome to the show. Can you see you now?
Yeah, I'm way too zoomed in.
Oh, yeah.
It's cross.
Oh, well. So we're going to take your questions tonight. And if any of you are following us, feel free to follow at Tenor Tettleman. I'm sure he'll be happy. Super nice guy, amazing voice, amazing voice, and hilariously funny, actually.
Oh, it's bonus.
Yeah. Fire away.
All right. So everyone's asking about endo, they say. I have so many endo questions.
Okay, fire away. I got answers.
All right. Just making sure everything's okay. Okay, so let's start from the top, shall we?
Yeah.
Question number 1. I have endo 2. I've had 2 surgeries for it. If I'm done with egg retrievals and prepping for an FET, lap, suppression, or both, would you recommend I take letrozole daily? And what about DIM?
So I don't know a lot about diethyl methyl, whatever it is, indole. I have to say it's not something I've looked up, so I can't answer that one for you. I did a show last night with Marissa Thompson from the Canadian Fertility Show. She's a naturopath. We talked about it a little bit there. She says there's no like solid evidence, but there's some kind of correlative studies suggesting it may be beneficial. From the standpoint of would I do surgery or suppression or both, I would definitely do both. And that's part of our protocol. And then we advocate for our whole protocol, which includes supplements. It includes high dose progesterone. It includes an immune protocol. Like we kind of tackle everything.
There's so many people on YouTube right now some say
awesome.
Like almost 100.
Wow. Hello, YouTubers. Fire. Maybe we need to switch the show to Mondays.
It is something going
Yeah.
on. So continuing on with that, is it normal for an endosurgeon to never follow up with his patient after surgery to discuss what was found or done? So frustrated with doctor, and then he puts the doctor's name, but we'll
As long as it's not me, we're okay.
Dr. Vidali.
Oh, really? Oh,
they're
I
saying.
love Dr. Vidali. No, I mean, that's probably a mistake, and he's a really good doctor and a great surgeon. So, no, I would just reach out to his office and make sure he follows up with you. I mean, in my practice, when I operate, we routinely see you post-operatively. And we set those appointments for 6 weeks because we need you to heal and recover. And often I need the pathology in our hospital slow for path. So, yeah, I mean, there's a lot of things that go into that time interval, but we always follow up. So I saw a whole bunch of my post-ops today. So yeah, we always follow up with you to go over things. Not everybody follows up immediately. And I don't, because the patients forget everything I say to them, but we do follow up. So if he missed you, he is a very, very good doctor. I would just communicate with him and see what happened.
Thoughts on FEMI for embryo selection?
FEMI?
Mm-hmm. I didn't want to assume it's FEMI.
I don't even know what that is.
There you go.
Never heard of FEMI before for anything. I have no idea what FEMI is. Frozen embryo microscopic something. I don't know. Somebody tell me what FEMI is. I've never heard of it. I can tell you that any type of AI based assessment of your embryos to date has not been proven to be better than the morphologic score that we assign the embryos, because the embryologist will look at the embryos, assess them, determine if they're good enough or not. And then if they're good enough, we choose them based on that categorization. If we don't feel they're strong enough, we go to the next embryo. So AI has looked at that, and they've never been able to outperform an embryologist yet.
Your YouTube is
cool.
Yeah. Just
all right.
Thought I'd let you know.
Excellent. Maybe YouTube finally recognized
playing
this
ball
again.
with us. Hello, Dr. V and social media T.
Oh,
big heart.
Love that.
Yeah.
Very nice. Yeah.
That's why I'm asking these questions. Like it's part and parcel here. For a 37-year-old endo patient,
Yeah.
doc advised 2 baby aspirin, as there is research regarding lower preeclampsia rates with taking 2 LDA versus 1.
Right.
Thoughts? Continued. Point number 2.
Yeah.
Compartmentalize this here. Is staying at 200 milligrams vaginal prog and stopping IM at 12 weeks safe throughout the pregnancy? Which patients do you recommend staying at 200 milligrams vag prog?
Okay, so answer to your first question is there is evolving evidence that higher risk patients should take more aspirin than just one. So 160 or 162 instead of the baby aspirin, which is 81 milligrams. That's quite a common thing to see these days. And more high risk obstetrics specialists, like maternal fetal medicine specialists, and even the fertility specialists, are going to that. I've been advocating for aspirin for so long, I can't even remember. And we made videos about it, I think, in the first year of this show. So it's been out there for a very long time, talking about the benefits of aspirin in infertility patients. So 162 is probably the appropriate dose for you. From a progesterone standpoint, we use 200 vaginally 3 times a day until we get them to 12 weeks. And then we cut the dose in half and continue it. And my rationale for that is it's very clear that progesterone supports the pregnancy and reduces preterm labor. The studies that have looked at whether or not you can prevent miscarriages and preterm labor have all been flawed because they start the progesterone after the pregnancy. But when you're doing IVF, you're starting it before they're even pregnant. And I think it makes a huge difference. So in my practice, we have a very, very low rate of preterm labor. And I think it's largely in part because all of our patients are on progesterone. So who do I put on progesterone? I put all my patients on progesterone, and I keep them all on the vag prog all the way up until 36 weeks, after which it's not really important if the baby's born at that point or not. They all do really well.
Dr. Victory,
Yeah.
besides acupuncture and following your RI and REI's protocol to the T,
Yeah.
at first I thought that was
For you. Yeah.
for me, but then I see that it's not. Are there any other little add-ons I can do to improve chances of my transfer on Friday?
Acupuncture, yoga, both have been shown to be beneficial. Follow the Mediterranean diet. Have lots of sex unprotected. Make sure he ejaculates inside, assuming you're in a heterosexual relationship. And otherwise, no, there's not a lot more than that, but that's probably enough to keep you occupied. Reduce your stress as much as possible. Find something you enjoy to help survive the 2-week wait. That's probably the only other thing you need.
Question from TikTok.
I
have stage 4 endo, and I had my egg retrieval with one immature egg retrieved.
Oh,
what would you do next?
Well, I'd need to know you and know your protocol. I mean, a lot of endo patients need appropriate priming. I see people every day that get estrogen priming and they have endo, and I'm just like, what? That makes no sense. So make sure you got the right kind of priming. Make sure that you got the right dosage of medications. Make sure you had the right trigger time. Was it a double trigger or a single trigger? Did they try and mature your egg in the lab? Were they prepared for that? Like, there's lots of things we can do to mitigate or to help you through your journey to improve the outcomes. So priming is huge. Like, if they gave you birth control first, that's a disaster. If they gave you suppression first, that's a disaster, both proven to be detrimental, especially in endo patients. If they gave you estrogen, that makes absolutely zero sense whatsoever for endo patients. So that's not a go-to. So yeah, there are ways we can improve it. DHEA, testosterone, human growth hormone, all of these may be beneficial in your circumstance. I'd need to know you. Tons of supplements that can be beneficial. We're going to be starting NAD plus infusions here soon. Sirolimus has been shown, rapamycin, to be beneficial in endo patients. So there's like a whole host of things we can do for you. Endo is a very different disease, and I actually got a good chuckle. T, you'll like this. Noticing that some of the other social media prominent fertility specialists have realized that we're taking the endo world by storm. So now they're like jumping on the endo bandwagon. Yeah,
there's a huge jump on the bandwagon.
There is. It was really cute seeing that. Thank you for imitation. It's the greatest form of flattery. And yeah, so there's lots you can do, but you need to be with someone that actually knows endo inside out and backwards, because some of the stuff I see other doctors doing, like estrogen priming for endo, I mean, automatically they're not thinking straight, or they're not well aware of what to do. So yeah, just pay attention to the details, find a team that can help you.
Dr. V and T.
Yeah.
Can I take Tacro and prednisone while being on Lupron Depot, and also add norethindrone acetate to lower the side effects of Lupron and letrozole? What dose should I take?
So I don't believe you should take norethindrone because there's no evidence for safety or efficacy in that specific situation where you're being suppressed for endo, and then you're taking something that resolves a lot of the symptoms of the suppression. So no, I don't advocate for that. Listen, I get it. The symptoms suck and they're terrible and no one should have to go through that. But we just don't have science to show that is appropriate or is going to be efficacious for you. So I don't advocate for that. For the, what was the other part of it?
Oh, Dr. Victory.
I'm sorry. Norethindrone I got.
Norethindrone, if I'm taking a Lupron and letrozole, will stop me and cause a breakthrough and bleeding.
No, it was another part.
What dose should I take? Side effects?
No.
Lupron and letrozole? Norethindrone acetate to lower the side effects of Lupron and letrozole?
Yeah.
What dose should I take?
Oh, I answered that. So yeah, I don't advocate for it. I thought there was another part to that question.
No, that's it.
Okay. Yeah. Don't do it because there's no evidence for that. It doesn't make sense.
No evidence.
Side effects to expect: hardcore menopause, night sweats, hot flashes, mood swings, vaginal dryness, sleep disturbance, decreased sex drive.
Don't do it.
Well, you have to because they need it. But if they take the progesterone, it gets rid of the symptoms, but then we don't know if they do as well. The whole point is to cause the suppression. You can't do the suppression without the suppression. So, but it does suck. And I'm very open with people about that.
Endosurgery.
Yeah.
First of egg retrievals, first 37-year-old suspected endo, visible adeno, 2 miscarriages, 6 IUIs.
Is there a question?
Endosurgery first or egg retrieval first?
Oh, I didn't catch that. Always egg retrieval first, because the egg retrieval will stimulate your estrogen levels to go high and you will be worse. So you have to have your treatment managed appropriately by making your eggs first so that the endo gets as bad as it's going to get. And then you go and do your surgery. If you do your surgery first and then you go and do a stim, your endo's coming back.
A lot of people are starting to comment. Happy birthday, Dr. V.
Oh, thank you. That's very sweet.
That's why we're doing the show today.
I get to chase my wife's boyfriend for my birthday.
You know, if there was ever a story,
that's the one.
That's
right?
the one.
Yeah.
That's the one.
Yeah. So we'll see how that goes. But yeah.
Yeah, I love it. Would love to hear more about your FET prep for patients with adenomyosis. Does uterine volume matter at time of transfer?
Well, uterine volume we know matters because you're at a higher risk of miscarriage if you have small uterine volume. If you have a large uterine volume, that's related to adeno. And of course, yes, the more adeno you have, the lower your chances are, higher chances of miscarriage, less implantation, all of those things. So we definitely advocate for our endo-adeno protocol. It's basically the same disease, so we don't alter it for adeno versus endo. We just kind of mimic the two things together and get very, very good results with that. So it's on our YouTube channel, but it has like 4 or 5 different elements to it. So first is suppression. Second is surgery. If you have endo, I don't typically operate on adeno patients unless they have an adenomyoma. And even when you do that, it sucks because it's horrible surgery. And then you have to do the high dose progesterone. And then when you've done the high dose progesterone, you do your embryo transfer. We keep our patients on many different supplements, which are anti-endo, anti-adeno. And then you need an immune protocol, which we have created and we use all the time. And in some patients with real severe disease, we started using metformin as well because there's evidence that it's good for those patients. So we have like a multi-pronged approach, and that's how we get it done. Probably the most important thing you'll see at VRC, I did one today, is that when your uterus is flipped over backwards because of endo and adeno, it's very difficult to see properly during an embryo transfer. And instead of torturing women by reefing on their abdomen with the ultrasound probe, which causes then cramping and close proximity to the uterus and the embryo and so on, we just do it with a transvaginal ultrasound. You get crystal clear visibility. They don't need to have a full bladder. You're not reefing on anything. And it's very, very easy to see exactly where the embryo is going. So you get perfect placement every time. That's critical when you're doing an embryo transfer in someone who's already got reduced chances. How many people know how to do that? Very, very, very few. It's me and 2 other people in the States that I know. I don't know of anybody else that does. Maybe they're out there. If any doctors are watching and you do it, please let us know. I'd be keen to hear from you.
Carly appears upset.
Oh, no.
That you saw her today and you didn't tell her it's her birthday.
I didn't tell her it's her birthday?
Your birthday. They didn't tell her it's your birthday. People are really worked up about this birthday.
I know, but I don't want to tell people it's my birthday.
Well, the whole internet is chiming with it now.
I will say it was great to see Carly in person. So, yeah, we love Carly. Carly's coming on the show.
Oh, fantastic.
You got to connect with Carly so she can come on the show.
Absolutely.
Yeah.
Absolutely.
And I'm supposed to go on her show, but that never panned out yet. So, Carly, let me know when I can come on the show.
Can a pregnancy be perfectly healthy with HCG on the lower side?
Yeah. So actually years ago, I think 2 years ago now, 3 years ago, we presented a study on the show which showed that the woman's age actually is predictive of how high the HCG needs to be. And the older you are, the lower the HCG is, and it's still viable. So there's definitely variations in HCG levels, no question.
Looking better. Causes of endometritis, not endometriosis.
Bacterial vaginosis, bacteria, ureaplasma, gonorrhea, chlamydia, strep, enterobacter, staphylococcus, yeast, low lactobacillus. Any of those can lead to it.
What state is this in?
What state is this in?
Yeah, people think we're in a state.
We're not in the States. This is good old fashioned Canadian maple leaf country. So we're in Windsor, right across the border from Michigan. But you are welcome to talk to us because I am board certified in the US.
Trying to have a hysteroscopy to remove a polyp, taking meds to start a period and letrozole. What do you recommend? I need to make sure it sticks. Progesterone cream, 3-DPO, baby aspirin. I have PCOS, and this is our first time trying. Should I add CoQ10, inositol, and magnesium and vitamin D?
Wow.
That is all of the comments to that question.
Vitamin D, yes. Fish oils, yes. Prenatal vitamin, melatonin has been shown to improve your chances. If you have PCOS, we use NAC, inositol, resveratrol, ALA, and the coenzyme Q10. So we add those in as well. Was that a YouTuber question that was asking what state this is in?
That was TikTok. That was TikTok.
Cool. Yeah.
Okay, here we go. It's always hard to figure out where you left off. There's no like highlighter. How many days before starting FET cycle should I stop? Oh no, we did something like that. Sorry. 3 millimeter fibroid in endometrial uterus with 20% of it in my submucosal. Should I get 25% of my submucosal fibroid removed by going in uterus to prevent miscarriage before implantation, or leave it alone?
3 millimeters or 3 centimeters?
Millimeters.
I'm going to question the validity of any radiologist that could see 0.6 millimeters being in the uterus. There is no freaking way that's real. You can't see a 3 millimeter fibroid on an ultrasound that clearly. So I wouldn't be doing anything with that. That's inconsequential. Now, if you mean 3 centimeters, that all has to come out. But 3 millimeters, I want to see the doc that can see a 3 millimeter ultrasound fibroid, like almost impossible. T is saying it's him. He could see it.
I've actually seen 0.01, but
0.01.
Who's counting?
Yeah.
How many eggs are ideal to be frozen before going forward with an FET?
That's a very confusing question. So we don't freeze eggs before you go forward with an FET. We freeze embryos. That's entirely dependent on whether you're talking about PGT tested or not. So studies show that 3 PGT tested embryos in a program that has roughly a 50% success rate will get you a 95.2% live birth rate after transfer. If you're not talking about PGT tested embryos, it 100% depends on your age, because the older you get, the fewer PGT normal embryos you have. So you may need to make a lot if you're older. And that's part of the reason we advocate for PGT. There is a study that just came out, or is coming out, that shows that the time to pregnancy is faster in women over the age of 38 when they do PGT, but not when they were less than 38. So that's interesting.
Correction, 3 centimeters.
3 centimeters. 3 centimeters, you got to get the whole thing removed. 100%. It's 100% increase in your risk of miscarriage and a 50% decrease in your success rate. Anybody that tells you otherwise doesn't know the data on fibroids. And I published an entire chapter of a gynecologic textbook, and it was all on fibroids. So trust me when I say get that sucker out.
Hello, doctors. That's us. When doing IVF, can the lab tell which sperm have higher DNA fragmentation?
Sadly, no. There is a device being offered by an Israeli company which allows you in real time to determine the degree of sperm DNA fragmentation using some sort of 3D microscope technology. We asked for it. It hasn't materialized yet. I'm not sure why, but we're keen to try it out to see if we can actually cherry pick the sperm, but I haven't heard anything about it since the time it came out. So otherwise, no, because the staining method we use to be able to differentiate high DNA frag from normal DNA frag or low DNA frag actually kills the sperm. So you can't use it after you've stained it. How are all our YouTube friends doing?
They're good. They say hello. They are saying hello and bonjour. I had a question here for you. Have you prescribed people on Ozempic? What is your take on this? I'm scared to get it.
I do not prescribe GLP-1s. We tried to get the rep here to talk to us about it, and they were so busy, they weren't coming. So, I mean, they're just making, money hand over fist. I can tell you, I know several people that are on GLP-1s. We've put a lot of patients through to physicians that do prescribe GLP-1s. And there's overwhelming anecdotal data and now more scientific stuff coming out as well, that it is very beneficial for fertility patients because it reduces your BMI. And no matter what anybody tells you, especially certain clinics in Toronto, your BMI does make a huge difference in your success rates. So that's really critical to be aware of. I'm happy to admit that I am currently on a GLP-1 because I was getting too heavy and I'm working so much, I have no time to work out. It is outstanding at curbing my appetite, which is great. And I've lost 10 pounds in 5 weeks. So yeah, I mean, it's working. I'm getting slimmer and it keeps working. And I just eat way less than I was before. I still enjoy my food. I've had zero side effects. It doesn't even hurt when it goes in. I usually pinch myself hard enough that the pinch hurts more than the needle does. So yeah, I mean, are there people having side effects? Yes. Should you use it without talking to a physician? No. But there are benefits to using it for sure, especially for fertility patients. I personally am not trying to conceive any children, so it doesn't matter in that regard for me. I just didn't want to get mistaken for a whale when I go to my cottage and go in the lake.
Nobody likes getting mistaken as a whale. Believe me. Danger. Yeah. Congrats. You look fantastic. Looking slim.
Oh, wow.
Oh, look at you.
Thank you.
Comments are just flying in here.
Yeah, that's good. You know what? Tell me if I look slimmer than I did before. For the regulars, I want to know if I look less heavy than I did before.
Looking fresh, Dr. V.
Looking fresh. Yeah,
absolutely.
If I ever slept, I'd look fresh. You know what the new thing is? People keep messaging me. They're like, do you ever sleep? I'm like, no.
I love it. Hey, Dr. V and Dr. T. Automatically a great one. All of our embryos were slow growing and had high levels of fragmentation. What could cause this?
Sperm DNA fragmentation would cause that. Poor quality sperm would cause that. Smoking, drinking, drug use in either of you would cause that. Bad egg quality would cause that. So it could be a variety of different things. Infection or complication in the lab could do that as well.
What type of vitamins do you suggest?
So we have basics. So we always tell you to take your prenatal, vitamin D, fish oil, and melatonin. Everybody should be on those. Beyond that, we break it down into what's wrong with you. Do you have endo? Do you have PCOS? Do you not have anything? And based on that, we determine what else to give you and what to do. So we have videos on it. It's on our YouTube. Just check those out. We tell you about which supplements to take if you have endo, which supplements to take if you have PCOS. Generally, many of them overlap. So NAC, resveratrol, ALA, and coenzyme Q10 are staples both for endo and PCOS. And then for the PCOS patients, we add in inositol. And for the endo patients, we switch that out and put in curcumin instead. I'm probably going to start using NAD+, and then there's meds we use, of course, as well. So they're not supplements or vitamins, but those are the ones we generally use.
Can you do booster lit when pregnant? My last lit was 5 months ago, and I'm about to do an embryo transfer.
You can, and actually there's data that I now have in my possession that shows that it actually improves your outcomes so that you not only can, but should do further LIT treatments into the pregnancy. So actually creating a package so that instead of just doing 2 treatments of LIT, we'll actually offer like 5. So we're working on that right now.
What I thought of?
What?
I should be on the show for the podcast.
I should interview you?
Yeah.
You know what? We should.
That'd be great.
The ultimate interview.
It'd be the ultimate
I
interview.
interview T.
Yeah.
That would be good.
That would be good.
We
Very
should do that.
entertaining.
Yeah. Who's going to do you? You got to give me the control.
I can still quote unquote do whatever this is, but it's all you. We'd be right here, just like normal.
That'd be cool.
Right?
We got to do it on the couch.
Oh, sure. Let's get real comfy.
We could get real comfy. We'll do it on the couch.
We'll have some drinks inside, some popcorn. Make a whole scene,
That's
man.
a good idea. We should do that. I like that.
Just popped in my head now. Let's make sure I get it out. After fixing everything with Fertility, anything specific to keep the microbiome at ideal levels aside from obvious basic hygiene throughout endo suppression?
Eat healthy. That's really important. Take your probiotics, oral and vaginal. Avoid any kind of sexual contact that could mess things up. Those would be the keys. Try and stay away from antibiotics in the interim.
I'm on 2 months of Lupron and added letrozole to my suppression protocol without notifying my doctor because he doesn't know about this, but I did. It's wild.
Oh boy. I cannot advocate for that because if they then put you on something that could counteract with the letrozole, that could be problematic. I'm a big advocate of telling fertility patients to run. If your fertility doctor is not listening, walk away. Like, your money talks. And if they're not listening to you, just go somewhere else. There's so many of us. It's not like, you're lacking in choice. Granted, there probably aren't very many of us that know what the hell we're doing with endo, but there's a lot of fertility doctors. So if your doctor isn't listening, go somewhere else. If your doctor doesn't know how to manage, I just had this conversation with a patient yesterday. If your doctor doesn't know how to manage a mini stim or a natural cycle IVF, go somewhere that does. If they don't know how to manage an endo protocol, go somewhere that does. I don't think you need to try and educate your doctor. That's not your job. And if you do need to educate your doctor, you got to ask yourself, why are you with that doctor? That just doesn't make sense.
That's a good one. That's a good one. That's a good soundbite right there.
A good soundbite.
Why are you educating your doctor? They could just come to me instead, to be quite honest. If that's the standard right now.
There you go.
Yeah, really. Can SERA be improved by CoQ10 and inositol NAD?
No. Smooth endoplasmic reticulum aggregates are problematic. No one has ever shown anything that improves that except for keeping the dose of gonadotropins low. So I spoke with a patient yesterday from the States. She had done mega high doses of stimulation and I couldn't figure out why. And she kept getting terrible egg quality. And I was like, this is crazy. She was the one that needed to do the mini stim or a natural just to see if getting away from those high doses will improve the egg quality. So there's no question that improving your egg quality, especially where SER is concerned, can probably be achieved by just exposing the patient to a lower dose of stimulation medications, because there is more and more data showing that the high dose protocols are very damaging to the eggs and should not be used.
Hello, doctors.
Hello.
What is your view on people doing MRT for age-related infertility, still producing eggs, but now producing 5-day embryos or euploid embryos? Thank you.
I haven't bought into MRT yet. For those of you that don't know, MRT is mitochondrial replacement therapy. So they take mitochondria from a younger woman and they put it into the, like from a donor source, and they put it into the woman. So the problem with all of this is, like, if you've got energy inefficient eggs, sure, it's going to help. But is it going to change your chromosomes in the embryo? No. And if your problem is egg quality and you have bad chromosomes in there, you're still going to end up with an aneuploid embryo. So the problem there is you're not actually really helping yourself. So I'm not a believer in it yet. I mean, maybe when someone's able to show me that it absolutely makes a difference and improves things, I'll believe it. But right now, I don't think we're there yet.
What are your thoughts on the use of Vitex with PCOS and Hashimoto's to regulate cycles safety during IUI and medicated cycles?
Yeah, Vitex is chaseberry berry. Yeah, it's great. Talk to a naturopath. I am not a naturopath. I know lots about vitamins and supplements, but I am not as knowledgeable about it as a naturopath is. So talk to Jen Strong or Laura Jasmine in our Sarnia clinic, Seeds in Toronto, Marissa Thompson. Like, there's lots of people you can talk to.
I had a stillbirth at 36 weeks after transferring a euploid embryo.
Oh my God, I'm so sorry.
2-3 doctors have told me this was bad luck and we most likely won't get answers from the autopsy. Do you have any insight? The pregnancy was all normal. There were no issues. The stillbirth was very random and shocking. I do have endometriosis.
Well, first of all, my heart goes out to you. There is literally almost nothing worse in the universe than a stillbirth, especially when it's late term. So that's really tragic. I'm so sorry. I mean, it's hard to know insights without knowing the pathology from the autopsy. I guess I would ask, did they do a third trimester ultrasound to assess growth? How often were you seeing the OB? Were there any cord accidents? Was the cord around the neck? Was there a true knot in the cord? What was the placental function like? Did they do a fetal echo? We're starting now to do fetal echoes in all our IVF patients moving forwards, and a growth ultrasound in the third trimester, because that's what SMFM, Society for Maternal Fetal Medicine, recommends. So I'm a believer in doing that, and we're going to be implementing that into our program. So I would need to know how they treated you. Were you on baby aspirin? How long do they keep you on progesterone for? All of those things can be important.
Dr. V and Dr. T. If sperm overnight progressive is only 4%, so not a lot of moving forward, does this also mean they are weaker sperm, or mostly just speaks to movement?
So all we know about overnight survival of sperm is that if it's below 56%, you have a less than 3% chance of success with IUI. Which is where it's valuable. And of course, if it's less than 3% with IUI, it's going to be even less when you're trying naturally. So that kind of low overnight survival is not conducive to success unless you're doing IVF. That's kind of what that means.
Why is estrogen, if only for a week, not right for endo?
Well, endo is an estrogen dependent disease. So why are you feeding the monster that's killing your quality and your outcomes and your success rates and your inflammation and your, all the different aspects of fertility, exactly what it wants to grow and be angrier? Like, that doesn't make any sense at all on any level ever. So don't take estrogen when you have endo. It's literally maniacal. It makes no physiologic sense whatsoever. And estrogen priming, and we've reviewed this on the show, has been proven to be useless. There is zero benefit to estrogen priming. So we do it very, very, very rarely in general, only if every other priming method has failed. And I'm like, okay, screw it, let's just try. And never in an endo patient, because that makes no sense.
So you know how you could tell your show makes impact? When people's comments answer people's questions. Yeah. So to that question, one viewer writes down, because it feeds endo.
There you go.
There you go. And then the response, of course, is, I'm asking the short term though. And she said, because, yeah, I guess that was
well,
it.
Even short term. I mean, you're still feeding the monster. Why would you feed the monster? There's especially something that's been proven not to be beneficial. What was interesting from that hailstorm post on Instagram about estrogen, a lot of people, even though it was crystal clear in the write-up, people didn't understand that it wasn't actually targeted towards hormone replacement therapy. It was just for fertility. But the wild thing from the comments was, there were a lot of women that said, yeah, like the estrogen made me feel wretched and horrible. And why did my doctor do that to me? And I was like, yeah, why did your doctor do that to you? But then there were other women that were like, I feel so much better on the estrogen.
Oh, interesting. Interesting.
And in fact, a couple of them were like, I'm only better when I'm on high dose estrogen. Just goes to show that everybody's different, right? Like one size never fits all. And if you're at any doctor or any program where they insist on only one thing, that doesn't make sense. So that's why we do use the estrogen priming protocol, but extremely rarely and only in people where we failed everything else. So, everybody's different. Some people will respond, and we're not at a stage in biological or scientific knowledge where we can like differentiate all the little minutiae that are going to contribute to you doing better or worse on this protocol or that protocol. We're just at the primitive stages of that. If you think of, all the knowledge as a human being, we're like at the embryo stage for the amount of knowledge we have on individualizing care for stuff like that.
Can there be severity of adeno? Can I go on to have a successful transfer with 3 months suppression?
Can there be severity of adeno? I don't know what that means. Yes, suppressing adeno will improve your chances of success. There's no question. That's proven. There's lots of studies on that. You can spend 3 seconds on PubMed or ChatGPT and it'll tell you that.
Happy birthday. And
thank you. Tomorrow, but thank you.
Yeah.
Yeah.
What are your recommendations for women dealing with autoimmune antibodies?
Well, it depends which ones, but we would have you see a naturopath and work on getting your antibodies down. We would work with you to do immune testing to help facilitate improved immune function. So intralipid steroids, sometimes Benadryl, depending on which antibodies are up, tacrolimus, sirolimus, whatever we need, Plaquenil.
What are the causes of placental abruption?
Smoking would be number one. Cocaine, trauma, high blood pressure, malformed uterus, multiple pregnancy. Those are the main ones.
Cocaine.
Number one.
Number one.
Number one.
Cocaine.
Smoking and cocaine are number one causes of placental abruption.
Wow.
Cocaine is severely vasospastic, arteriospastic. Sorry, I got something in my eye. So when you snort cocaine, it actually causes the blood vessels to immediately snap shut, which is why if you end up in a merge with a torrential nosebleed, they actually shove cocaine up your nose.
Oh, no way.
Because it'll stop the bleed.
Oh, wow.
Right. So
they have that on the shelves in the
they have cocaine in the hospital for that.
On.
Yeah.
Oh, wow.
So
because
that's not one you want to learn, buddy. So because it snaps the blood vessels closed, the connection between the uterus and the placenta is vascular. It's blood vessels, right? So there's all these blood vessels going in. So as soon as you snap them closed, you pull the connection apart. That's where they're connected, and how they're connected is those blood vessels. So you close the blood vessel connection, the placenta's like, I'm out of here. And it just falls off.
Oh, man.
So cocaine is number one. Yeah.
Wow. Happy birthday. Love
thank you.
Yeah.
Oh, thank you. That's very sweet.
I've had multiple ultrasounds with you. Today I found out FET was canceled due to adeno.
Yes.
Why?
So I looked at your images because I know who that is, and it looks like it was not seen before. And I looked at the images and there were equally good images. It looks like you kind of developed this recently. So I don't know if it's from STIM or it's just evolved from what we've been doing, or it's just highlighting more now. But I looked back on the other images and wasn't there. And today it was very frustrating. I know, because I looked at it, I was swearing my head off at myself, but it wasn't us. It just, the images before look normal and the new ones don't.
I'm on Endo Finks since seeing you in Dublin.
Oh yeah.
Suffering with endo pain. Recommended to talk to you. That could be, that's.
So she's on EndoFix from our buddy who was on the show.
Oh, Connor?
Yeah.
Oh, okay, great.
Connor Curley. So yeah, I mean, that's a great vitamin supplement. I support that. It's actually a really good product. But if you need further help, just do the consult with us and we'll help you out.
What is the likelihood of a pregnancy after laparoscopy to remove endometriosis?
Well, if you look at the studies on this, and there actually shockingly are not many, it's an 80% increase in success. That's trying natural. If you do it with IVF and those things, it's a huge improvement in success over your baseline because you're getting rid of a huge amount of the inflammation. So that makes a big difference in your success rate. What time is it? I don't have a watch.
7:45, sir.
Oh, it's flying by.
Flying. Oh, yeah. Yeah.
Speaking of flying,
Yeah.
do you have to do a special pickup tonight after all, or no?
No. No.
All right, good to know.
Should I be laughing about that? But I do not have a special pickup.
Yeah. We're going to go see Fantastic Four.
We can do whatever.
Yeah.
Yeah. I had a full-term stillbirth 6 months ago and chemical pregnancy last month. Worried about fertility.
Oh my God. I'm so sorry. Reach out to me. I will help you get appropriate testing. It's critical you do testing. That kind of history is suggestive of thrombophilia or immunological problem. There are ways to figure it out. So before you do anything, including getting pregnant, reach out to a specialist, me or anybody else who's an expert in determining causes of stillbirth, miscarriage, recurrent pregnancy, loss, implantation failure, all of that stuff. And keep in mind that, and here's one of my gripes with the fertility world, the vast majority of fertility specialists don't do obstetrics anymore. And I think that's a shame because they lose the ability to know what's happening in the obstetrical world. And that's important because if you're having a stillbirth and they don't know what's wrong and they're trying to get you pregnant, you could actually do real harm. So for example, let's say you do have a thrombophilia and then you get told you need to do IVF because you're worried about your fertility. If I drive up your estrogen levels and you have a thrombophilia, you're at a massive increased risk of having a blood clot. And you need to be anticoagulated during your stim and immediately after your retrieval. So make sure you follow up with someone that really knows their stuff and is going to address you as a holistic kind of approach and as a whole person. Otherwise, you may end up having someone drop the ball. And that can go very, very sideways very, very quickly.
What are the chances of becoming pregnant after a voluntary sterilization and 2 previous live births?
Huh?
Yeah, I don't know.
Super high. I mean, I don't know what you mean by voluntary sterilization. Do you mean you tied your tubes? If you untie them and you're young and healthy and your partner's sperm is good, your chances are high. If they're still tied, it's basically close to 0. It's 1 in 1,000. If you're talking about a voluntary termination, like an abortion, then your chances would be super high. So I don't know which one you're referring to. It's like a whole, flow chart that goes off in my head every time I get one.
Yeah, but
I gotta
you're deducing everything.
Yeah, you see those memes where there's all that math.
Absolutely. Oh,
that's going on in my head every time.
Absolutely.
What are they talking
about? Smooth endoplasmic reticulum aggregates. Oh, okay, good.
Is that the same one?
I don't know.
SERA?
No, can be improved with CoQ10. Yeah.
We did that one.
Is cycle monitoring up and running in St. Catharines?
Yes.
And can you do intralipids there as well?
I believe they're prepping for intralipids because I asked about that last week. And cycle monitoring is up and running. Yes. Yeah.
After 3 spousal lits, the recommendation is donor lits.
Yeah.
Are there 2 donor lit sessions still required if IVIG is also in the transfer protocol, or can you get away with 1?
We would advocate for 2 because IVIG will not necessarily cover all your bases when you're dealing with low LADs or Treg cells and stuff like that. So we would still advocate for 2. I do know it sucks because it's expensive. It can be made cheaper if you bring us someone. Otherwise, we have a slave that we use as vampires to suck blood from on a regular basis. So he just keeps coming in and giving us blood, but we do STD testing on him nonstop. So we know he's squeaky clean. Plus he's, without spilling the beans, kind of related to our program, not me, but our program. So we know him. He's a good guy.
Unexplained infertility. 4 field transfers,
Yeah.
1 chemical pregnancy, 3 no implantation, clotting panel and immune antibodies are normal. What to do next?
I would want to see your immune panel. I would want to see the shape of your uterus. I would want to see your partner's sperm. I would want to see your embryo quality. I would need to see your microbiome, your vitamins, your thyroid function in detail, body mass index, social habits. Like there's a lot we do to figure that out. And that's why we're so successful, because I check every single thing and then we figure out what's wrong and then we fix it. And that's how we get super high success rates. But just reach out, get a consult. Plus, we're hiring somebody new, so our wait list is going to drop soon.
So shape of uterus, that important to figuring out?
Oh, massive. I see all these people where they've got this like massively T-shaped uterus, right? It's like this. It's supposed to be like an upside down piece of pie. And it's just like a T, like it goes up and then there's a bar at the top. I'm going, did they not tell you have a T-shaped uterus? No, no one's ever mentioned that. I've done like 6 embryo transfers. I'm like, what? How could you even have, like, how could they have missed that? We did that post.
Yeah.
That was a patient that reached out to me.
Wow.
She's like, this is with my uterus. What do you think? I'm like, you need urgent surgery. Like, that doesn't make, she's like, no, they told me it was fine. That's not fine.
So you have to fix the uterus first.
That's like I give you an apple and
Yeah.
you go, this is the nicest banana I've ever seen.
To that extent.
Yeah, like
There's just no
like how could it possibly make sense? It was
Wow.
bizarre. Nonsense.
I'm telling you, it's wild.
Just crazy. Crazy talk.
MMC of a normal embryo at 10 weeks, normal uterus, normal coagulation panel. Possible reason.
Immune, infectious, sperm DNA fragmentation, thyroid disease, obesity, elevated or super low BMI, terrible diet, exposures to smoking, drinking, drug use.
What metformin for in transfer protocol? When do you start the meds before transfer calendar or at the beginning?
Metformin you should start months in advance if you need it as part of your transfer protocol, because it causes gut rot and people do not feel good on it. It takes a long time to kind of stabilize. So don't be doing that till you're ready.
Happy birthday, Dr. V.
Thank you.
We're at the start of our journey.
Okay.
How many months can I take letrozole for? I'll prescribe for 1 month only. Also, do I have to take medroxy again?
Well, you take medroxy if you're not getting a period within 35 days and you're not pregnant, because you need to induce the period to start the letrozole. So, although you don't actually have to do that, but we normally do. You can actually just take letrozole again, and in many cases it'll work. In terms of the letrozole, you can take it indefinitely. It's just a matter of how old are you, how patient are you, how long do you want to keep trying for? So yeah, I mean, there's no harm to taking letrozole, but you know, you may lose your opportunity if you keep doing it and you're 42 and you're doing a year of letrozole. That's not a good idea. So it depends on a lot of different factors. Well, you got that smirk on.
It's a very interesting term I just read.
Okay.
I don't know if you've heard it before. Well,
Right.
You must have for sure, but it's the first time reading it. What's the truth about sperm living inside of the body? If I can only baby dance on Monday, but ovulated Friday, do I still have a chance?
Yes. Baby dance?
Baby dance.
Yeah, that's having sex.
Yeah. I like that.
Yeah, it's a good one. Yeah. So there's a older study which showed that up to 5 days before the ovulation, there's still a chance. I forget what the exact number was on the 5th day before, but it's like 10%, something like that. 8%, 10%. I don't remember exactly, but it's like a curve that goes up as you get closer to ovulation. And then the day after ovulation, it's 0. You will not get pregnant the day after. So up to 5 days before is still reasonable, because there's these little like crypts and spaces in your cervix and along the endometrium that can kind of hold the sperm and store it. And then every once in a while, they'll break away and go up to the egg.
Here's a good one. They're all good ones. Let me take that back. They're all good ones. Have suspected endo and adeno diagnosed with mapping ultrasound. Is there a point in trying that transfer without excision, but with 2 months of Lutron, continued with 2 months of Lutron and letrozole? Have had no idea what have had, but that's where they're basically going with that.
It depends on how many embryos you have and whether or not you are willing to risk one. Do I think that just being on Lupron and letrozole for 2 months, if you have bad endo, is enough? No. You need the rest of the protocol, the high dose progesterone, the supplements, the immune protocol. And surgery often is really necessary, or else you're still just battling inflammation. But is surgery mandatory for everyone? No. I mean, I tell my patients, because we have to wait so long for surgery, if you're, if you're someone that has 10 good embryos, try one or two. If it doesn't work, then hit the brakes, get your surgery done. But if you've got only 1 or 2 embryos to begin with, that's more concerning. I wouldn't necessarily jump into it.
There are a lot of stats you give on female age and eggs and embryos as IP with donor eggs. I wonder all the time if I use her age as stats or what.
When you're trying to determine your success rate, if I'm understanding the question correctly, when you're trying to determine your success rates for using donor eggs, it's very dependent on the program you're working with. The average is around 50 to 60% per embryo transfer. Personally, I would shoot myself if our success rate was that low, but that's what the average is. If you look at good quality programs, it's higher. Our success rate per cycle is off the charts. So I can only tell you this. It's good enough that in the majority of cases, we are willing to provide a live baby guarantee, which means if you don't walk home with a baby, we give you most of your money back. So, I mean, I know how good we are and what we can achieve.
Charles wanted me to let you know that you look good.
Oh, thanks, Charles. I haven't seen you forever. How are you? How's the baby?
Yeah, you definitely look good, she says. Can a woman get pregnant naturally with open tubes and no fimbriae? Fimbriae?
Almost impossible. Yeah, it would be super difficult. The fimbriae are the little projections at the end of the fallopian tube that are actually used to pick up the egg. So if you don't have fimbriae, how's it going to pick up the egg?
Can't pick up. Can a woman get pregnant naturally with open tubes?
No, we just did that.
What are the causes of placental abruption in an IVF?
Too.
Hey, what are your thoughts on pentoxylene after 2 failed transfers? Pentoxylene, yeah.
After failed transfers?
After 2 failed transfers, yeah.
I've never seen pentoxifylline for that use. The only thing pentoxifylline has been studied that I'm aware of is for thickening the endometrium. It does work, but we used it. It's got a lot of side effects, so we backed away. I haven't used it in, 15 years, longer. Can I just hit a pause button for a sec because we're nearing the end of the show?
Hit the pause.
I just want to thank everybody because our social media has gone off the charts recently, and it's been really exciting for us to put in all this effort and finally see the reward. So thank you for watching and for supporting us. It is a labor of love for both Tarek and myself, and we appreciate you guys very, very much. So thank you. It's a best birthday present ever, I think I can say. And thank you to Instagram for finally recognizing us after 6 years of busting our nuts for this. So yeah, we really appreciate all your advocacy, your shares, your likes, your comments. Yeah, even the crazy people that think vitamin K is bad for babies.
Very important to the formula.
I appreciate them too, because it was like I felt like I was in fight mode, like,
fight mode's good.
Bring it.
Base price for IVF, Dr. V.
$6,750.
Carly said she wants to go on Ozempic after she gives birth, please.
Carly, you're beautiful. You don't need Ozempic.
How long do you recommend one to be on PIO after an FET? And do you ever recommend longer than 12 weeks?
we continue until 12 weeks of gestation, which is like 9.5 weeks from the time of the transfer. And do I ever recommend going beyond that? Only for the patients that can't tolerate vaginal. For those ones, yes, but otherwise, no. Oh, is it?
It's 8 o'clock. I guess you got an hour. That's all they're going to give you.
Yeah, TikTok always gives us an hour. Oh, you have to restart the whole live?
Yeah, dumped everybody.
Oh, no. Sorry, TikTokers. Yeah.
801.
One last question.
One last question. Sure.
Because you and I are starving.
Yes, absolutely. Absolutely. And I got so many things going on right now. Okay. Hey guys. I guess that's
us.
That's us. Yeah. If I have a short luteal phase, 10 days,
yeah,
should I be taking progesterone? Will it be unlikely that I will get pregnant as the egg won't have time to implant?
So short luteal phase is actually being studied and demonstrates no impact on fertility. So it won't impact your ability to get pregnant. Would I recommend progesterone? Yes. But we do that for everybody. So yeah, that's a good idea. Time's up, or do you have like a thrilling question? Because you've got that.
I'm looking for a thrilling question. I was just reading. Someone said TikTok left me, and they're so pissed off about it.
TikTok's annoying.
Yeah, it's got that moment there.
So for all of you who are watching, including the TikTokers, and maybe hopefully someone from TikTok, we can't put TikTok on the platform that we use to simultaneously broadcast to Instagram, Facebook, YouTube, and what used to be Twitter, X. Because when we put TikTok on the software, it says we're not creating an original video. And so it boots you off. And so we can't fix that. And in the past, when that wasn't the case, and we did do it, we got way less views on TikTok, probably because it thought we were cheating and rebroadcasting somebody else's video. So we have to put TikTok on my cell phone and we put everybody else on software. So I can't fix the TikTok thing because we can't see the phone unless we have a whole other person here, which we don't. This is the Tarek and Rahi show.
Tarek and Rahi show. You know what we could do? We could, but then it'd be so much more effort. We could screen share we could mirror. We could open up a window here, mirror.
Oh.
And then at least we'll
and
know.
Then you'd know, and you run over.
And then we could just run over and swipe.
Oh, that's a good idea.
That's a good idea, right?
Maybe we'll try that next time.
But your battery will drain double the speed, but I think it's worth a try. Yeah,
we can plug that in.
Yeah, we can plug it in.
Oh no, we can't because we got your mic.
Well, let's see how it goes. Let's see how. Just make sure you're like 90% before the show starts.
Yeah, we can try.
Yeah, we could try. 8:03. I think you're good.
We're good. Lots of love. There will not be a show next week because I will be on holidays. And so I wish you all the best. I am off to Germany for a couple of days and then off to my cottage after that.
Super cool. So are you gone for 2 weeks or 1 week, by the way?
Just like 10, 11 days.
2 shows missing or 1 show missing?
Just one, because we did this one.
So we did this. Oh, because we did this one.
I'm missing.
Wonderful. You're
next
missing.
Week.
You're missing the 5th.
Yeah,
and you're back. You're right. And you're back.
Yeah.
Oh, good thing we did it today. You're right.
But I'll make some videos. I plan to do some damage on the Autobahn and some fun cars. So
nice.
Me and JT. So it'll be fun. And I hope you all have a wonderful, August long weekend. And for those of you that are struggling, please reach out. We specialize in helping people that have problems that other doctors can't solve. And this is where you come to get all your myths busted because I hate stupid.
Hating stupid. It's good. Good answer.
So someone on the Canadian Fertility Show thing I did yesterday said, I was ranting about poor treatment of women. And they jokingly said Rahi for president or Dr. Victoria for president. And then they messaged me and she's the lady that makes the brownies.
Oh, wonderful.
Oh my God, I love those brownies. Yeah. And so she said, I'd vote for you. And I said, yeah, I would make a terrible leader because I would just be a dictator. I have no tolerance for stupid. So anyways, you all have a lovely evening. Thank you for joining us. And we will see you in 2 weeks' time. Back on Fertility Fact or Fiction, and maybe based on tonight's numbers, we may change the night. Who knows?
Well,
we'll see.
You never know.